I think we should start now. I'm getting a double audio from here. I think we should just stop it. There's a double audio is coming from here. So if you can just reduce the audio from there. That's good. Even now, I can hear something. No? Yeah, check. Are we good to go? I just need some feedback if my audio is all right. I think if the admin can let me know that. Who's the admin of that? Just can you ask if the audio is all right?
Yes, doctor, it is good,
Audio is
doctor.
okay? Yeah. Thank
Yes,
you.
doctor.
Thank you, Rohit, for that. Yeah. So good morning, everyone. This is Dr. Anand Krishna here. Bright on a Sunday morning. I know it's a little warm in Bangalore, but yeah, this is a wonderful time of the year where a lot of holidays and some festivals around the corner. We just want to spend this Sunday with a little bit of academia, where we want to give some introduction into digital dentistry. See, my background is I'm a prosthodontist. I do implant dentistry routinely. We've been into teaching, research, and practice of implant dentistry and high-end restorative dentistry from the last 25 odd years. We began quite a few startups. As you can see some of them here. Global Dental Academy is where we are bringing this particular webinar from. We also began implant study group about 20 odd years back, me and my partner, Dr. Girish Rao, where we train people on various levels of implant dentistry. We have the fellowship, the foundation, the master's program, and special programs like All on 4, the Zygoma, and the prosthetic digital prosthetic protocol program. 3D DDS is our digital dentistry wing where we provide solutions for dentistry through the digital means. Of course, My Dental Plan is a dental insurance company. So, and Sasomi is our society, which we began. So there's many of these things that we have started up. And today we are talking on the platform of Global Dental Academy, which is one of the verticals of Global Healthcare Academy, founded by Dr. Ajay Kumar from the HCG fame. He is one of the most known names in the country when it comes to medical entrepreneurship. He has achieved pinnacles in this particular field where he has established multiple startups under the Healthcare Global and Global Healthcare Academy names. So this is one of the verticals of GHA. What we do in GHA is, again, most of the things that we were doing in implant study group have all been incorporated into this. So today's focus will be on digital dentistry. And this seems to be the buzzword for last year and a half, where post-COVID, this has come into the limelight. So we want to kind of try and understand what these entails, because it's not that every dental college is teaching a lot of digital dentistry, or some of us who have graduated quite some time back, we don't have any avenues to learn some of the basics of this particular thing. That's the whole idea, to give kind of a broad overview of what is going on in digital dentistry. We will show you some of the essentials of intraoral scanning, how to make the scans accurate, what is the scope of intraoral scanning is something that we are going to try and demonstrate to you. So towards the end of this lecture, probably I'll come out of this lecture and bring in the intraoral scanner and try and show you how these things work. So that's some of the things that we want to do in this 90-minute odd lecture. So digital dentistry has come as a boon to dentistry. There is no doubt about it. Many things that we were practicing or we were trying to teach in a very abstract manner, today it is very definitive. Visually, it is possible for us to explain things. Dentistry was always an amalgamation of medicine and engineering. We were considering mechanical engineering as one of the mainstays of the engineering part of dentistry. But today, if you do not know the software or the digital part of the engineering, it's not possible for you to practice dentistry to the highest level. Most of the things that we were doing in an analog way, which was taking almost hours together, is completed in just minutes with digital dentistry. So let's try and see what is the overview of the whole aspect of digital dentistry that we are talking about, both the clinical and the laboratory aspects. And then we will go ahead and try to some demonstrations. So why digitization? Is it just one of those things which has come in newly and everybody is talking about it? Or is it really meaningful? Is something we have to try and understand. First of all, it is quick. There's no waiting time. There is no setting time. It is only processing time which is there. So as a matter of fact, things that we would spend probably about half an hour to get a good impression, we can do it in a matter of minutes when it comes to intraoral scanning. It's very accurate because because digital dentistry is all light based as of now. Of course, it is going to be infrared based and things like that in the future. But right now it is light based. Wherever the light can pass, wherever it can be captured, data acquisition is what we call it now. We don't call it impressions. We don't call it any other aspect. We call it as data acquisition. Data acquisition happens immensely by the type of technology that you're going to use. That is something which is very, very helpful. It is insightful and intelligent because it is in a software based or a software backed kind of an environment. We can always make it artificially intelligent in the sense I can recognize in an impression that this part is something which is not proper, there is an undercut here, or if the preparation is not proper in a tooth preparation kind of a setup, with the help of, say, a surveyor, with the help of certain instruments. But here, since we can do machine learning, the machine can tell us that there is an undercut here. The path of insertion of the bridge or of a crown will not be adequate. It will not be possible for you to fabricate a crown. So it will give you that kind of an insight into the whole problem of prosthetic dentistry. So that is what we mean by it is insightful and it is intelligent. We can visualize. For example, an aligner case. Of course, we are going to have this aligner lecture next week also. So in an aligner case, the patient can visualize what is going to be the final outcome. So he or she can see the various phases of treatment, or if you consider a complicated implant case, we can show you exactly how the final outcome would be. We can integrate data from the facial scanner with photographs, with the CT scan, with the intraoral scan. We can do all the integration of data and we can actually put it out there into the software. The software will allow you to manipulate and give option 1, 2, 3 to the patient as to how the final outcome would be. So you can do multitude of these things just on the software environment. You don't have to physically do wax ups anymore. You don't have to physically do impressions anymore. You can just bring all the data onto the software environment and you can work with it. Less people intense. So last year in the International Dental Show, we had the AI design a single crown and actually mill it and produce the whole crown. In the sense, for a single prepared tooth, the AI itself did the whole laboratory protocol without people at all. So that's another thing. So a single designer today can handle up to about 40, 50 crowns without a problem. So, and the milling happens and it is less people intense. Earlier days, when you enter into a laboratory, it used to be messy. There used to be a lot of people. There's a lot of screaming going around. You would know the earlier share market, how it used to be. That's how even a laboratory used to be. Right now, today, what we are seeing is most laboratories, at least the digital laboratories, look like a software company. There are only people working on softwares, and automatically you can see that the milling unit starts and it goes on milling. So it is very, very um, people people friendly today. It's not very, very people intense. Seamless integration of the hardware and software. Today, what we are seeing is moment you do an intraoral scan, you can integrate the scanner with the printer, which can be chair side, or the milling unit, which can be chair side. So moment you design and push it into production, it can go ahead and produce the crown for you chair side itself. So some of these hardware software integrations have something which has helped improve the quality of work, and also help the improve the quality of life of the dentist. Because as a dentist, what do you want at the end of the day? You want peace of mind, because your work, what you expect, is coming out as expected, and it is coming out accurately. For example, just a single crown, when you talk about prosthetic dentistry, a single crown would be very stressful sometimes, because moment you make the impression, send it to the lab does the die cutting, pour the model modification, do a wax up, probably make a metal coping, and then ceramic layering. So you know that there are many materials that are involved here, and there is a lot of expansion contraction which happens. At the end of the day, the crown which comes back might not actually fit. There are chances that can happen here. But today, what we are seeing is when you do the scan and when you send it to the laboratory, it is almost like it is automized, in the sense there is no model making for single tooth crowns. You can just make it modelless. You can go ahead, design the crown, mill it, polish it or glaze it, and send it back. You're not even layering in most of the cases. More than 95% of the situations, you are not having layered crowns. That's how the dentistry is moving today. Very, very few cases you're doing layering, unless it is a metal and ceramic crown. That's a totally different topic. But mostly it is the non-metallic crowns that is going on today. Mostly it is monolithic crowns that are coming up. Of course, I will take all the questions at the end of this lecture for sure. I'm sure many of you will have some inputs, some questions regarding this whole thing. Yes. So how we are looking at workflows. Earlier, we used to call it as clinical protocols. Today, we are calling it as workflows, because most of it is digital based. The first thing that you do is data acquisition. We want to acquire as much data as possible, whether it is from the intraoral scan, whether it's from the facial scan, whether it's from the CBCT scan, or whether it is from the model scan. We want to acquire data first. Then we want to plan and design. If we are executing something like, for example, if you're doing guided implant surgery, then you would want to plan it on the software environment using this data. Then you want to execute the plan. That's a surgical plan. Then you acquire data again in the form of scanning of the implant impression. And then you go ahead and do the designing, do production, aesthetic and quality check, and then you send it across. So that's how the workflow would be. So the first thing is what we are generally talking about today, how to acquire data in different ways. Of course, I'm going to also show you designing and production to a certain extent, where I introduce you to the different machinery that is available in the laboratories today. I have to admit, as clinicians, we are probably 10 years behind a good laboratory. Laboratories have adopted digital dentistry and digital production technologies much faster than the clinics. We see clinics today, even today, trying to make impressions and things like that. But most laboratories have done away with the casting machines, have done away with wax ups. They all do digital designs and productions in the form of milling or printing. So we are going to talk about and give you some overview about that. So data acquisition, plan, data processing, designing, production, and layering. That's how it works. This is how the data acquisition happens. So this is some of the pictures of the various scanners. On the top, you see the intraoral scanners. There are different generation of scanners that are available. They are wired, they are wireless. Multitude of these have entered into the market. Many of them are of good quality. Yes, it is quite difficult for you to choose which scanner to go in for. That's another other topic, but we will address that. So this is the extraoral or the facial scanner that you can look at. This is Meti Smile from Shining 3D. These are model scanners. The model scanners, these three are the model scanners that you have. This one scanner can also take the articulator. Can you see this? The articulator, this is the SAM articulator. This is the Aman Girbach articulator, which actually can, because when you're doing full arch reconstructions, you would want to do a face bore transfer and a semi-adjustable articulator. So how do you scan the semi-adjustable articulator with all those readings of the mountings that you have? So you have a model scanner which can accommodate the semi-adjustable articulator, and the same readings actually uh, come on to your software. So these are the model scanners, intraoral scanner, and this is the facial scanner. Of course, the CT scanner is another type of data source that we can have. That is basically for surgical planning, that we require both the hard tissue and soft tissue data from the CT scan can be brought in, and then we can plan guided implant surgery through that. The technology of the intraoral scanner itself, it is based on the principle of wavefront sampling. That means to say there is a light source which is actually reflecting onto the surface, and there is a camera which is absorbing this, so that we can capture multiple photographs, and the software behind it is so powerful that it stitches all these things and it will visualize and it will give you something like a 3D image. So wavefront sampling is something that is the principle of intraoral scanners. This is how a typical intraoral scan would look like. So you just have a wand, you have a light source and the camera in the wand. So the tip can be changed. So you just go ahead and you run it along the teeth, first on the palatal aspect, okay, then on the occlusal, and then on the labial. So that is the way that you would want to show the wand to the surface that you want to capture. Of course, I'm going to show you many more of these videos. So this is just how the principle of intraoral scanner, how it works. And then it captures and it stitches it up. So there is a powerful software which is driving all this. So the performance of your intraoral scanner is dependent on the intraoral scanner itself, but also it is dependent on the processing speed of your computer. So the computer should have a high-end graphics card, at least a 4 GB or a 8 GB graphics card, which is very important for data processing of the video that you're or the camera that you're using to record. So that's very, very important for you to have. And you do the maxilla, then you do the mandible, then you do the bite. So that's how you're going to record this particular data. Next is the model scanner. If you send an impression or if you send a model to the laboratory will quickly get this onto the model scanner and digitize it. This is how the model scanner would work. This is a typical kind of a dashboard that you see where you enter the patient data and kind of basic details of what you're trying to do with it. And the model scanner will take only about few seconds, about 3 seconds to 5 seconds to scan a model. This is real time. If you can see that it's already scanned a model. So you do the maxilla, you do the mandible, and then the bite, so that you get all the three data into your software. So typically today we take about 30 to 45 seconds to scan a full arch in the intraoral scanner, about 5 seconds in the extraoral or the model scanner. That is how it works. That is how a model scanner is doing its job. This is the facial scanner. This is quite recent. There are only a couple of companies which have the facial scanner. So now, what is the idea about having extraoral scans is because when you want to integrate facially generated aesthetic dentistry, there is a 2D photograph that we are using and trying to work with it. Instead of that, if you have a 3D facial data, that is when you can actually do facially generated aesthetics. This is going to become more and more popular simply because this was not available for us. We had not kind of worked with this technology, but if you see here today, this is the facial scanner. You can see that this patient has some kind of hemifacial microsomia type of thing, some facial deformity. So we want to actually bring it because it involves the teeth, it involves the face, it involves the plane of occlusion, it involves the aesthetic plane, it involves also some part of the nose. So we want to try and see if we can do some kind of modifications where, see now what we are doing the facial scan with the retracted pose. We can also do it in the smiling pose, and then we can do the, see this is how the patient looks like. You can see that there is quite a bit of facial deformity. This is the intraoral scan of the patient. So we bring in both these two and merge. We put some markers, say 3 markers on the, we recognize and we tell the computer or the software to merge these two parts. So the intraoral scan and the facial scan is merged. So now if I go ahead and do some changes on the intraoral scan, which is possible by the software for me. So if I make any changes there, the same changes will reflect on the face. So it is more realistic that these changes are possible, because what happens, the kind of problems that you have with a 2D image like a photograph, and trying to do some changes in that, it looks like as though you're just photoshopping the whole thing. Whether that is actually possible in the patient is something that you'll always be having trouble with in estimating, because it'll look fantastic on the photograph, but the same thing when you try to translate that into meaningful patient work, sometimes you'll be left with a lot of discontentment, because it is not possible for you to get that particular outcome. But here, when you do facial scans and integrations with intraoral scanner, that thing will not happen. So that is the advantage of using a facial scanner. Of course, for maxillofacial work, it is a boon because we can print, say, for example, this patient also had some ear issues. So we can, if the patient's ear is missing, we can go ahead and copy the opposing ear and print it. So it makes your life so much more easier. There's not much of sculpting that is required. There's not much of manual labor or artistic work that is required. You just have to print it. Today, it's possible for you to print resin material. Maxillofacial resins can be printable. Only some extrinsic and extrinsic coloring will be required, and then you can go ahead and generate a maxillofacial processes. This is the CT scan that I was talking about. You acquire the CT scan. This is a patient who had a huge tumor kind of thing in the in the nasal uh, area, nasolabial area. So we are planning for some implants. This is the denture plan that is brought in. That is the CT scan of the patient which is brought in. We're trying to put in some zygomatic implants. You can see that you have placed the implant virtually. This is the final prosthetic outcome. That is the denture. You go ahead and plan it. And once the planning is done, this is how it looks. So here there is not much of guesswork that happens. You can see the final prosthetic outcome and the implants. Everything that you require for your surgical planning is already here. So you go ahead and you kind of these are some of the anchor pins that are being planned to hold this particular stent in place. So you go ahead and visualize the whole thing, both the surgical and the prosthetic aspect. You're sure that this is something happening. And this is the stent that you have generated. And using that stent, you can actually go ahead and perform the surgery. If you see here, this is Dr. Girish Rao operating on the quad zygoma that we had planned. This is the nasolabial or a premaxillary tumor which has been removed, and that's the stent. We just extended the stent a little bit onto the zygomatic area because we wanted a bone support all the way there, because zygomatic implants, as you all know, is quite long implants. So we want the stent going all the way there. So that is how the stent got fixated. And you can see the entry holes of all the 4 zygomas. And those are the drilling sequences that is happening. So the idea is you don't want to kind of change the angulation of the zygomatic implant. If there is about 5 or 10 degree change in angulation, it means that the implant will be entering either the orbital area, or it will go into the temporal fossa. So you don't want these things to happen. You want to be exactly in the position where you're coming out of the lateral aspect of the zygomatic bone. That's the implant. So sometimes we do the drilling sequence with the stent in place, but when it comes to placement of the implant itself, it's always better that you do freehand, especially when it comes to complicated cases like the zygoma. You want to be seeing where the implant is going at all point of time. So you would want to do it freehand. But if it is just an alveolar implant, you might as well do it with the stent in place. So that will help you get the final position of the implant also in the correct area. So once the implants are placed, so that's both sides of the implants. I'll just quickly rush through this. All the 4 implants had gone in, and that's how it looks after the 4 implants have been placed. So we're happy with the positions. These are zygomas with an angled neck. You want the angle to be pointing downwards. That's the metal ceramic bridge which was fixed. These are all multi-unit abutments. That's a small palatal hole which remained, that we covered it with the flap. And this is the final bridge process that was given for the maxilla. So for some period of time, we had to give a removable plate on the palatal aspect, but after it had healed, we closed it up with a flap. So that is how this case progressed. Designing, once data acquisition happens, you send it to the lab. And today, more and more softwares are available for the clinician to do the designing. So we see that in Blue Sky Bio, we have Exoplan, which you can do. You can also have the softwares which are given along with the intraoral scanner. For example, Shining 3D, Itero, Medit, all these companies of intraoral scanners gives you apps in which you can design your own crown. You can have a chair side resin printer, which you can use to print the temporaries, or today even long-term provisionals can be printed with the help of these machines. It's only a matter of time before final restorations made of resin can be printed in-house. So if you're looking at the future, every clinic will have an intraoral scanner, every clinic will have a resin printer, and many clinics will also have a milling unit. A tabletop small milling unit will be there. So if you look at, say, 20 years back, when I began dentistry about 27 years back, I used to see clinics, right? Okay, this clinic has X-ray facility. Intraoral X-rays were not very common. Every clinic would not have it. So you would refer intraoral X-rays to another clinic and try to get an X-ray and try to see what to do with it. About, say, 30 years back, that was the scene. So about 15 years back, we still had a lot of practices not having a OPG. Today also, a lot of practices don't have OPG X-ray. You would refer it to many other places for OPG centers. But most clinics today have already a orthopantomographic X-ray. It definitely would have an intraoral X-ray. The same thing will happen with intraoral scanners and printers also. Today, you're trying to outsource work when it comes to crown and bridge work. At some point of time, that will also come in-house. So if you just have a printer, all you have to do is you have to approve of a design and print it. I mean, the software will do most of the proposal, in the sense, for example, here, what manual work our digital technician is doing. See, first is margin making. You can see that the undercuts were there. So he blocked out the undercut digitally. He said, yes, this is the crown. So the software gave a proposal. He is adjusting this. He's bringing in what type of occlusion he wants. And then he's just modifying a bit of, see, for example, if you had to carve this particular molar, it would take almost about half an hour for us. As prosthodontists, we all went through this training, rigorous training of anatomy, and we went through the wax-ups. So when you do wax-ups like this, it would take almost about half an hour, and our professor, Dr. Solomon or Dr. Sridhar Shetty or Dr. Chetan Hegde would say that, oh, you know what, this is not even up to the mark. So all your half an hour's work would go waste and you would start doing it again. But today, the software does most of the work, and you cannot go wrong with the software. It will analyze the occlusion, it will analyze the occlusal surfaces of the adjacent teeth and the opposing teeth. It will have kind of already a proposal which will fit into this particular situation very accurately. It will go through different iterations in the background. It will process and it will give you the most suitable kind of occlusal morphology for this particular case. That is how it works. And it takes only a couple of minutes for you to modify it. And if you're able to do this, if the software is helping you more and more, see, that's a little bit of modification that you're doing. Occlusion is already in place. Now you take this particular STL or this particular crown, and then you put it into the printer or the milling unit. So that is how you go ahead and manufacture this crown. Yes, we are working on ExoCAD. ExoCAD is one of the most powerful laboratory softwares that is available, and that is something used worldwide. This is a little more complicated case where it's a full arch reconstruction, which is being done. You can see that we are trying to bring in a virtual articulator and developed canine guidance for you to explain to the technician what canine guidance would be and how he has developed it would be a nightmare for you to check before the work actually came into your practice. But today it's definitely possible for you to check all this in the design, approve it, make modifications, say your curve of spee you're not happy with, you're not happy with the intercuspal positions of the teeth, so you're not happy with the contacts, you're not happy with the morphology, you're not happy with the tooth form, not happy with the texture. So every single aspect of prosthetic dentistry is so easily visualized and communicated today. One of the major aspects in restorative dentistry is communication, your communication with your patients. You try to show your patients this is what you can do. Your communication with the technician communicating with you backwards in the sense like he is trying to tell you what is possible on the articulator is something which was always a gray area. Today, it is solved to a great extent because I will not allow my technician to go ahead and complete a case without me seeing the design. When I see the design, I see it very intricately for all these aspects that I talked about, and then I give a go ahead. So if I'm not happy at any particular stage, I will say, no, please modify XYZ things. Many a times, even the patient visualizes this. We send it to the patients and we say that, look, this is how your tooth form is going to be. This is how your final work is going to be. How would you, I mean, we call them for a discussion on designs itself. And once the patients are happy with it, only then we produce it. So earlier days, until the crown actually lands in your office and you put it in the patient's mouth, you would never know what is the morphology that is followed or what is the kind of outcome that you can expect. But today it is very, very predictable because everybody is on the same page. That is, the technician, the clinician, and the patient is on the same page. You know what you're expecting. That has solved a lot of problems for us in restorative practices. So that's what is the advantage here. So here, if the technician is trying to show us the canine guidance, if I say no, make it into group function, he will go ahead and just make some modifications in the occlusal morphology and bring it into a group function type of occlusion. So all these things is possible. Once the designing is complete, then we go ahead and we do production. Production can be milling and printing. These are the two broad types of production strategies that we follow. Milling is reductive manufacturing, where you have a block and you carve the block and make it into a desired object. The disadvantages of milling is that there is a lot of wear and tear of drills. There is a limited access of milling. That is, the type of shapes that you can get from milling is limited when it comes to printing. It is just infinite amount of access that you can print with. Will need some kind of post processing like sintering or hardening. There is more wastage of material because you're carving something out, you're reducing this whole thing. So that's the reason why milling is done for some materials. But the main advantage of milling is that you get a very dense type of material. What do you mean by dense type of material? When you compare a printed material versus a milled material, the milled material will definitely be stronger as of today. This is a stronger technology than printing. In the sense, the strength properties, the hardness, everything will be much higher in a milled product than a printed product. The advantages of printing is that it is additive. There is absolutely very less wastage. You can print to whatever configuration that you require. There is no limitation in that. You can even print something which is hollow, but you can't mill something which is hollow, right? You can't make a hole and cover it with all the sides with a material. That's very difficult, but you can print a hollow material. can print only certain materials because today the printable materials are resins. You can print acrylic, you can print metal. Zirconia printing is technically possible, but it is still not very popular. There's only one company which has made this zirconia printers, but it's still not very popular. Material hardness is not as much as in milling. There's very little post processing that is required for a printed material. So this is the two types of rapid prototyping techniques that we follow. I'm going to show you how a milling works and how a printing works. These are all the different other processes. This is how a milling unit looks like. This is a milling unit that is available in our laboratory. These two are the tabletop milling units. Yes, these are the various milling units that are available. So there is process called as dry milling, and there's a process called as wet milling. So we are going to talk a little bit about it now. So this is how we actually mill. So the designs that you have done on the software is exported into the CAM software. So the designing is done on the CAD software, that is computer aided designing. Now computer aided manufacturing is something that you're going to do now. So the export file format is called as STL, Standard Tessellation Language. That is the type of format universally for all machines, whether it's a printer or a milling unit or any other type of manufacturing is done by STL files. So this is how it is done. This is called as nesting. In nesting, what you do is, this is the way this particular crown would look like. This is the block. That's the block of, say, zirconium. You're manufacturing this in zirconium. So you have a block of zirconium. You're going to place this crown at a particular position. So if you see that there are different gradients of color, because this is a pre-shaded blank. The pre-shaded blank has graduations in which the top is the enamel or the occlusal surface that it should be, and the bottom is the cervical area. So already when you get the crown out of the milling unit, you will have different colors in that particular block itself. So you've seen earlier days, zirconia used to be one color. It used to be very white in color. Once you mill it, you would dip it in coloring liquid, or you would actually put ceramic on top of it. So that's the way we used to work. But today, these are pre-shaded blanks. These already have colors in it, and the color is not uniform. There are different shades of color. So you position your crown in such a way that different aspects of the crown will have different shades of the same color. So that is how it works. And you give supporting struts. So what happens is, when you want to mill a particular block and when you want to mill a crown, you need to have supports for it. And that is how the supporting units are brought in. This is very similar to the casting and the sprue formation that used to be there. This, you can see a blank getting fixed onto the milling unit and the milling actually beginning there. And you see that it's carving the internal surface of the crown. And this is a very soft material, which is zirconium. Zirconium is very soft before it gets sintered. So once this is done, then you push it into sintering. If you see this, the drill is actually carving it, and in real time, this is just about 5 minutes it can carve. And that's how you can see that this is a premolar crown, and you can see the supporting struts which are there. This will be bigger than the actual crown, because this is a soft blank. This is a pre-sintered blank. So what happens is when you actually go ahead and remove this, this will be like chalk powder. It is very, very soft. This is put into the sintering furnace for about 8 hours, and then it gains the correct size, and also it gains the correct strength that is required. So this is a blank from Aman Girbach. They are the world leaders when it comes to zirconia blanks and zirconia milling units. That's the same video. This is metal printer. This is also called as DMLS technology, direct metal laser sintering. This is the machine that we have at 3D DDS. It's called as E+. That's the machine from Shining 3D again. And that machine can print metal. It is powder of metal, which is put in. If you can see here, that's the bed, which is getting cleaned, and that's the ring. You can see that it goes from bottom to top. So that's the powder. That's the chrome cobalt molybdenum powder, which is actually kept in a preheater. And then once it is heated, you bring it on, you pour it into that well, you design and you nest it. And that's how the printer actually works. It pushes the material and the laser hardening happens. Again, the same way, you nest it. This is the nesting. So you bring in all the elements that are required. In the sense, these are some of the crowns, customized abutment, a bridge, which is all designed with the help of the Exocad software. The STL is sent on to the CAM software, and this is all nested. Once the nesting happens, the supports are given. These are the supporting struts, because to print, you need supports, and supports are given there. And this is sent for printing. When it prints, you can see that the laser is actually going ahead and it is hardening that particular area, and new metal is getting pushed, metal powder is getting pushed. That is how it goes. I mean, the ring sinks in and the printing happens, so that it gets printed in layers, and that is how it looks. You can see that the struts are there, and you can see all those components which are given for the print and nesting has come out. So at the end of printing, you just cut these supporting struts, take it away, and then you polish it and you process. If you want ceramic on top of it, if it's a implant bar, you go ahead and work accordingly. So that is how you go ahead and do the metal laser sintering. That's how it looks. So it's possible for you to print chrome cobalt molybdenum. It's also possible for you to print titanium today. So you, instead of putting chrome cobalt molybdenum, you have to put titanium powder, change the parameters, and then you can also print titanium very effectively today. This is a resin printer. This is something which is going to be a part of your clinical setup in the future. You can print wax patterns, you can print provisionals, models, you can print dentures, you can print surgical guides through this at this point in time. You can also print aligners in the future, but as of today, you're still not able to print aligners with the help of this tabletop printer. This is how the printing works. Again, the same way, if it is a model, you design the model and use a model creator, export the STL here, you bring in the STL into the bed on the software. This is the CAM software. Say you're printing this implant model, you go ahead and do it in layers. This bed will come down, it'll harden, it'll go up, it'll keep going up and down until the whole whole model is formed. Again, the supporting struts on the bottom. You can see the implant wells being there. This is the gingival area that is being cut. You can see that the two implants on the distal aspects. And that is how the models are printed. In the same way, you can print temporaries, you can print wax patterns, and you can also print some models there. So these are the various materials that we use in dentistry, in prosthetics. We use wax, we use PMMA, we use resins, we use zirconia, we use lithium disilicate, otherwise called as Emax or Cameo. We use composite resins, we use metals, and we use PEEK or bio-HPP. So the materials that can be dry milled are wax, PMMA, and zirconia. The wet milling happens with lithium disilicate, composites, metals, and PEEK. These are all wet millings. Printing can be done for most of these materials, but today it's popular only for wax, PMMA, resin, and metal, and sometimes PEEK. Still, PEEK is not very popular as printing. PEEK is polyethyl ether ketone. This is a brownish material. The advantages of PEEK is that you can make implant abutments and implant frames and cast partial frames with it. The biggest advantage is that it's very, very light. If you make, for example, a zirconia frame of, say, a maxilla, you will have about close to about 30 grams. But the same thing, if you make it with PEEK, it'll be about 5 or 6 grams. So that is how much different the weight would be, and it's quite strong. PEEK is known to have the same modulus of elasticity like that of bone, which means to say when bone bends, the strong materials like zirconia, which does not have any flexion, does not bend. So there's a lot of kind of stresses that are accumulated in the frame. So if you've made a mandibular frame, for example, and there is mandibular flexure, this flexure flexes the jaw, but if the framework doesn't flex, like you made it with zirconium, which doesn't flex, there's always a stress concentration, so that you can have fractures in your frame. That's the reason why many mandibular frames done from molar to molar fail. So in such scenarios, if you use something like PEEK or bio-HPP, they are materials which are flexible. It has the same modulus of elasticity like that of bone. So that also flexes and you do not have fractures. That's the whole idea by which PEEK frames are made. So you need to, when you think of materials, you also have to think of multitude of biomechanical factors, what can fit into that particular situation, what are the forces that are acting, what are the bending forces that are acting. So when you think of all these things, sometimes PEEK emerges out as one of the best materials to do complex reconstructions. This is how the materials are supplied. This is a block of Vita anamic. This is a hybrid ceramic. This is a combination of composite and ceramic. This is a high-end aesthetic material. What you can see here is the Empress or the CAD blocks of composites also are there, of lithium disilicate is also there. These are zirconia blocks which are there, and this is a wax block which is there. So there are many materials that you can use. Just to conclude this lecture, so digitization is the way forward. Multiple new technologies are emerging and making its way into dentistry. Understanding it, implementing the same, improving the quality of care, improving the quality of life of the dentist is something which makes it very meaningful. You have to train, you have to adopt, and you have to practice. So this is very, very important. If you have learned something in the past, you have to unlearn it, is because it is already redundant. If you have learned a lot of wax up, you have to unlearn many of these things, but the basics are something which is very, very important. Where you know the basics of waxing, you implement that knowledge in very easily into the digital world. That is how you have to do it. As a part of this, we are also starting the digital dentistry skill enhancement program. We have announced it in the month of June. Those of you who are interested can please enroll with us. GDA is always welcoming for newer technologies and newer courses. So we want to bring in something like intraoral scanning, the extension of it using the apps and all that. We want to bring in implant planning into it. We also want to bring in smile designing. These are the three main key areas. And of course, a small part of aligners is also going to be there. So it's going to be a 2-day program. Please get in touch with the GDA team. They will help you take it forward. So now, once we have completed this, let's just go ahead. The lecture is only half over. There's a lot of things that I want to show you with respect to intraoral scans. So I'm just going to come out of the presentation, go on to this, and start my video. I just want to know if the video is being shown. I just want the admin to see if the video is shown.
Okay, doctor.
So I'm going to show you some implant scans, how an implant scan is done. This is a scan strategy, how to do implant scans. I just have to wait until I get a feedback. If the video is seen,
No,
video
no,
is not
doctor.
seen, I will stop sharing and I will reshare it, and I will say that I want to show the media. Yeah, yes. Is it seen now?
Yes, yes, doctor. This one.
I think it's seen now. So I'm
Yes.
going to show you how an implant scan is done. I'm going to show you how the designing is done and how the production is done. Then I'm going to bring in another laptop which has the Shining 3D which is attached. I'm going to show you how to use the apps. I'm going to show some cases where you can show aligner mockup and things like that. So I'm going to show you functionalities of the software with that. So just stay tuned. The lecture is still not over. So that's how the scanning is done. There's not much of there is a small learning curve with anything. It's not much. Probably in a day or two, you will get the hang of it. You just have to focus on the area that you want to record and think of it like a camera. What would you do if you want to click an image or when you want to do a video? First thing is you want to keep it still and you want to make slow movements. You're not going to make jerky movements. That's what even when you do intraoral scans, the same thing. You have to make a slow movement from one side to the other with continuity. So the way most people record their scans is, first of all, they are going to do the palatal aspect. When you do the palatal aspect, so the software knows that this is the arch that is being recorded, right? When this happens, this is used as a reference and the further images are captured. That is how the intraoral scanner captures an image. It makes mark one, or it takes a point one, and it records the point two and relates it to point one. So what happens is there is the reference points which are created when you record, and the further points are added on, and that is how an image is recorded in full. So that is how the palatal aspect is recorded. Sorry, it's a little fast. So you record the implant well. You can record it either with the healing abutment in place, or you can record it without the healing abutment in place because this is a two-step strategy of recording. So once you do that, then you carve out that particular area and you fixate the other areas. This is the scan abutment. This is the scan abutment, which is specific to this particular implant. A scan abutment is something like you can see in this inset as to how the scan abutment looks like. This is similar to the transfer post that you use to make analog impressions. This is a digital scan abutment, okay? Or you can also call it as digital impression post. So this digital impression post is actually fixated onto the implant and you scan the impression post there. So when you do that scan of the impression post, at this point of time, you see that the rest of the model or rest of the anatomy is all fixated. You cannot re-record this. This is all fixated because you're going to record only this. The problem with implant is that the implants are inside the bone, and how will you record it? Like any other transfer impression, right? The implant is inside the bone. So you will have to put something on top of that. Something which you put on top of that is not going to look like a tooth because the intraoral scanner is trained to capture tooth configurations mainly. If it is a geometric configuration, many a times it is regarded as something which is like an artifact. Most implant or most intraoral scanners have artifact elimination AI, which is incorporated, which means to say something like the cheek or the tongue or the mouth mirror that you use, everything can get recorded and it gets automatically eliminated because of the AI. So that is what happens. So when this happens, you can sometimes it might recognize the scan body as something artificial and it can eliminate it. That is the reason why you fixate the other portions of the scan and you record only this. So you're telling the software, look, I'm recording for an implant. That's the first thing. Second thing is you're also telling, do not record any other aspect. I'm going to show you where the implant is. So I've already removed some portion of the gingival area there, and I'm going to put the impression post, you record only that. So that is how you are indicating to the software that this is something which is of an implant scan. You can see that the implant scan is done. Then you do the opposing scan. Once you do that, you do the bite scan, and the bite scan actually brings in the maxilla and the mandible together. And once you optimize it, you can see that the maxilla and the mandible is both together, and it will also have the scan body there. That's the finalization of the scan. When we go into the next video, screen share stopped. I'm sorry, I'm going to open another one. Just going to come out of it. And I'm going to do screen sharing again. I'm going to share it. So this is how this is of a different case, but very similar. Single tooth implant restoration. You've brought it into the designing software. That's the scan body that you can see. So you have eliminated some portions which are not required using the lasso tool. You have now that's you've brought in the digital implant analog. So if you want to make a model, you bring in the digital analog, because once you match this particular implant scan body, automatically this analog will set in and it will give you a possibility to make the model. You mark out which is your gingival area, mark out the maxilla, and then bring the analog also there and fit it into that particular slot. You can print the model, and on the model, you can scan the model again using, I mean, if you're putting a straight abutment there, you make the modifications and put it in there. And then it's just like crown bridge. You actually go ahead and create the margin. You can go ahead and put a tooth there. And once the tooth is put, you create occlusal morphology the way you want it. You want to incorporate all your knowledge about implant occlusion, implant protected occlusion. You go ahead and do that. Here you have done a full wax up, and then you are going to make a reduction coping. Reduction coping is made when you want to do layering of ceramic on top of it, either for metal and ceramic or for porcelain fused to zirconia types. You can see how much is the thickness of the ceramic that is coming in. So you go ahead and do all those things, and then you go ahead and do the milling. This we already saw how the milling is done. That's the milling, and then you polish it. You fit it in. And you glaze it. Once you glaze it, and that is how some small occlusal corrections, very hardly any occlusal correction would be there. Some amount of staining is definitely required. You actually lute it. Most of the single crowns that we do today in the laboratory is luted, is pre-luted in the sense we send the crowns with the luting in place. So you just have to remove the healing abutment and fix the crown in the patient's mouth. That is how easy it is today for you to actually go ahead and work with implant crowns. So that is how you finish a case with single implant. Now I will just shift on to the software where I can demonstrate to you what is the possibility that is going to be there with the implant planning, sorry, with the intraoral scanner. I want to connect to that one. So leave that there. I just want you to share screen from that. Okay, just it'll take a couple of seconds for me to just switch over the camera. This one you have to put it there. I will stop sharing from this and I will start sharing from the other screen. I'm already logged in there. Yes. Okay. Can you take this off and put that? So big thanks to the GDA staff for coming on a Sunday. Everybody's Sundays. They have come in right and early here by about 8 o'clock. They set up the whole thing here. So I'm going to show you. Screen sharing is ready. My audio is working. You're not hearing anything. Turn off the audio. Now? Sorry? Now? Yeah. So I was just saying, shout out to the GDA team. They came in very early today at about 8 a.m. to set up the studio. I don't think you need that circuit. Just stop recording this. You don't need to record that. Yeah, it's connected. Camera is connected. Okay. So I'm going to show you this software where market as. Why is there echo? Now it's okay? No, I'm still hearing my own voice. Let me just type in demo. This is how the. I'm going to show you a aligner demo. Let's see this. This is how the when you want to begin a particular case, this is how it works. Let me just go back. Let me just add a case. Say I want to record a single case of 06. I call it as demo. Just want to add the age of this. Yes. Accept. I just say which clinic that I want to work with and which technician I want to work with. I can name the tech. I can actually be very specific. I want to just say Ramya. Just don't want anybody to work on this. I can write this. I can say it's an implant restoration. I have to indicate whether it's just a restoration or it's an implant work that I'm doing, or if it is orthodontics, or if it is some other thing. I want to do an oral check. Today, with the technology that we have, we can use an intraoral scanner as an intraoral camera. We can also use it for caries detection. That's possible because of the type of light it reflects. We can measure early dental decay. We can give a report regarding this. So this can be recorded and it can be sent over to the patient. So that's definitely possible. So many of these things are possible today. Say I just want to do a restoration. I just go ahead and I just go ahead and say scan. So it will give me an option of the scanner. Okay, I say yes. I pick up the scanner. This is the intraoral scanner that is getting picked up. So the maxilla is what I'm going to do now. Sure. You see here, it is already getting recorded. Yes, please.
If they want to see the device, you can shift the camera.
You can check the camera.
You can have to change it.
Just for the shift. Not even started. Okay, you're seeing the device also now, the video. So it's multiple things are streaming. That's why it's slow comparatively, but otherwise it's much faster. Because the same processing is happening through the video and also the intraoral scan. So you scan the maxilla. So now once the maxilla is scanned, just want to drop this. Give me the bit of my, try to record my finger there. See that? I'm trying to record my finger, but it's not recording because it knows that this is not a part of what it wants to record. That's because of the AI function which is there. If you actually go ahead and switch off the AI, say here, can you see my screens also? They are seeing my screen, right? On the right hand side, there is an AI function which I'm removing, and then I'm trying to scan my finger, which is just attached to that. Why am I trying to do this? Because I want to show you another function. I've recorded a part of the finger. Go ahead and I've completed the scan. She is just coming. So this is the scan that I have done. I'm pretty happy with the tooth scan that is there. But there's something in excess here. So AI function is switched off. That's the reason why it is recorded this. I go ahead and snip this. There is a tool in which I can just snip this. I don't want this to be a part of it. Just going to remove it. Okay, that is possible. I don't want all the areas, so I remove it.
You can shift the camera now to your face.
Done that. So I said yes, I'm happy with the model. Now I want to see if my if there is any isolated data, it can be removed. I want to see the undercut. So I want to say that I just want to see if there are any undercuts in that particular tooth. So you can see this is the gradation of the undercut which is there. So if this is the path of insertion that I've seen, when I have this path of insertion, you can see that there is an undercut, and I can say that that is 0.1 millimeter undercut. It shows you the color gradient here, and there's very severe undercut here. See, when we do cast partial dentures or any other removal process, we need to have a path of insertion because you have created a tilt of the cast. I don't know if many of you remember from your lectures on surveying in prosthodontics, where you try and harness some undercuts for retention, and some other undercuts are blocked out because it is coming in the path of insertion. But here, if you see here, if your path of insertion is this, okay, you have an undercut of 0.06, everything in the green region. So you need to block out this particular portion if the crowns have to be seeded properly. So you can change your path of insertion. You can keep it here and say, I want a path of insertion like this. So it changes its path of insertion, and you see that the undercuts have come in different position. And that's severe undercuts. You don't want severe undercuts. So you want undercuts to be minimal, and you choose a path of insertion where your undercuts are minimal. Here the undercuts are bare minimum. You can see that just a few areas can make the measurement of that undercuts. So this is something which becomes very important. Even in training, if you want to train people how to do tooth preparation, this is a valuable tool, because earlier you used to just eyeball it and you say that, okay, you know what, you have undercuts, but even the student did not understand what undercuts were. Even the teacher was kind of wanted to tell it just for the sake of telling, because the more you reject people's work, they always feel some kind of ego massage. They are not sure, but most often it's just that the technology did not allow you to actually very objectively measure things like this. See, here you have a 0.01 millimeter undercut. I mean, that's the same if you're a teacher or a student who's preparing this, it's just going to be the same. So that's something that that you could do. All these things comes naturally to a software. You don't have any great amount of work that you're doing at this point in time. You're just pressing a few buttons and saying yes, that's what I want. So the same way you go ahead and you can do the mandibular arch and do the bite for you to go ahead and say then it optimizes and finishes it. So just want to come back into this. So I go back here. I want to show you a case of aligner because yeah, last 10 minutes. So I'm also going to give you about 5 minutes for some questions. Yeah, that would be nice if any of you can drop in a message on the chat box about some questions. We are more than happy to take it forward. So this is the aligner case. Of course, I also told you that you're going to have an aligner lecture next week. So this is a case of which we have already done for an aligner. So I'm just going to come in and see what can be done. So orthodontics, I can do fixed orthodontics, removable orthodontics, or invisible braces. So what do you mean by fixed orthodontics? You can't do any fixed orthodontics on the software, but you can create trays. You can create bonding trays where you can carry the brackets and you can go ahead and fixate it in the patient's mouth and just cure it with some composite. So a prefabricated position for the brackets can be done very easily. We just have to mark the center of the cone, right? And where, how it has to be moved. What is the existing position and what is the final position? How you get that? Of course, the orthodontist next week, Dr. Prakriti, she will be able to explain that more. But say, okay, I want to do invisible braces. I'm showing this more from a perspective of of the software, not of the technology, not of the technique itself. So you press that and then you go ahead and scan. Let's see how the scan looks like. Want to do that? Just want to bring in existing scan. Original data which is already scanned. Just want to bring in. So the extension of this software is the apps. The apps can create all these additional things where you can create a temporary, you can do some designing, you can create a surgical stent, you can create a aligner, you can also create the splints or the pre-bonded brackets and things like that. So all those things can be done with the help of the apps. So this is the intraoral scan that I have procured. Okay, you can see the maxilla. You can see that there's a lot of crowding and the highly placed canine there. Mandible, we just removed a tooth there, so there is a tooth which is not in position. We want to correct it. So this is the bite, how it looks. Now I want to go ahead and want to use the apps. So how do I use the apps? I just go here and I say I want to go to this app with Shining 3D is called the Console OS. So I just enter that. So just take a minute or so. By the time, if you can just type in your questions that you have, I'll be more than happy to answer those. Because it's entering into the app. Now I want to do tooth segmentation. So the software will automatically detect which is which tooth. No? So every tooth is separated and we actually go ahead and we can move those teeth the way we want. So tooth segmentation is something which is happening now. Is there a question? Which intraoral scanner to invest in? Okay, this is a question which is I'll address that. So now this is how the segmentation happens. You can see that every tooth is kind of separately colored and where it has to be moved, all those things. Then you enter setup. So it will prepare a plan for you. It is setting it up and it is kind of making also some movements. Okay, it is already working in the background. This is the kind of final outcome presentation that you can do to your patients, and you can see that you already have that. It's already showing you that this is possible. You can kind of making it to a video and send it to the patient. To the state and which is there. You can show it. You can make it into a video. You can upload it. You can um, convert STLs. If you say there are 10 models that has to be created from the original state to the new plan, you can print those and press it in-house. So all those things are possible today just with the software itself. So this is how the you can see that how the movement happens. So this is real time. No? This is how I am sitting and generating it. It's not that it requires too much time or effort. I'm just with a few buttons that I'm actually going ahead and creating this. And once the patient sees it, wow. First of all, when the patient sees the intraoral scan itself, you know what? I've never seen anything like this. Is the kind of wow factor that you have. I've never seen my tooth like this. I've never seen the decay like this. When you put it on a big screen and show this is how your decay is, the patient says, wow, I want to get it fixed. This looks ugly, you know. Or if you do a makeover, something like this, you say, yeah, this is something that I always dreamed of. So things like that, you generate a wow factor to the patient. So now I'm going to stop sharing my screen. We'll take some questions. I think the first question was, which intraoral scanner would you use? Scanner, yes, it's like choosing a car. There are many features for each scanner, and it becomes important what is the intended use that you have and what is the extent of use that you will have. So today, most scanners are of a minimum standard. Earlier you would have scanners which were really, really bad. Cheap scanners were not scanning at all. Some things that you would want to bear in mind is the size of the tip. The size of the tip, the overall handling of the scanner itself. The scanner is too bulky. It becomes all the more difficult for you to go ahead and scan intraorally, especially the distal aspects of the tooth. So the size of the scanner becomes very important. The software that is associated with it makes all the difference, if you ask me. If your software is not fast enough, it cannot capture, it cannot process, then that is something that you should not be going for. Scanner is just the device part of it. The software part of it is very, very important. The additional features like the AI integration, additional features like the apps are something that you should look at. You should try and work on the software. The trend today is most people feel that, okay, the scanners are brought by the lab. You would not want to do that. Okay, it's as a beginner, you would want to do it for a couple of cases to just get the hang of it. But would you want to do it on a long term? No, you would not want a technician to come in and scan in your patients. You are the clinician. At the end of the day, you are responsible for it. So which scanner to invest in? First of all, you have to, it's like which implant system do you want to invest in, right? It's almost similar to that. What is the technology that is there? How is the accuracy rating? How is the depth of view? Today, the depth of view can range anything between 15 millimeters to 22 millimeters. So you would want to consider that. Whether it records the metal objects well is something that you want to consider. Whether it has all the apps is something that you would want to consider. Those are the kind of questions that you would want to ask. Of course, the cost does matter. Actual difference between the 5 lakh scanner and the 10 lakh scanner, between 5 and 10, there's not much of difference, but between the 5 and 25, there's a huge difference in the technology that you're using, because not every scanner works on the optical wavefront technology. There are many, many technologies which have come in, which can capture faster, more accurate than what is there in the other scanners. Definitely, the accuracy between the scanners are much different. You will have to, I mean, this happens at such a fast rate that you would want to go through literature which is latest, which is kind of published this month before choosing a scan. What are the specifications? Yeah, we talked about it. Any precautions to be considered to take a scanner? You know, you would want to test drive it for quite some time before you actually go ahead and invest in one, because every every clinic will have more than one scanner in the future. But as of today, scanner looks like it's a luxury in the market, though the prices have dropped very drastically. That yes, but still not all clinics will have a scanner. So you need to probably use it a few times. You have to see the accuracy from the laboratory aspect. You're only seeing it on the screen, right? When you convert it into an STL and when you print a model, what is the kind of accuracy that you can get? Especially in the earlier days, the concern that was there is when you have moisture, how it records, the edges, that is the margins, how it records subgingival areas. Those are things which were a big question mark when it came to first generation of scanners. They always said the marginal adaptability is very poor because the record in that area is never moisture free. So today with the scanners, even with a bit of moisture, it can record very well. Of course, if you put a gingival retraction cord and record, it is like probably better than an impression making. So you would consider this from the laboratory aspect. You also would send send the STL file to the laboratory and see how it looks before actually investing in the scanner. Any precautions to be considered for the scanner? Don't go in for very cheap things uh, that you would want to go in for. See, some of the scanners I see that they do not even have a software. They have a software which only records and sends. They don't have any post processing that you could do. That is something that you should look out for. You should not be investing in very cheap scanners, because cheap things, the only thing that you can get cheaply is bad quality. That's what I think. Any free apps available for ortho simulation and designing the foreground? Yes, today Blue Sky Bio. I don't know if you know, it started off as an implant planning software. This is something which is kind of become the basis of digital dentistry. You download Blue Sky Bio, you bring in your ortho simulation, you can bring in crown and bridge, you can bring in your implant planning, everything that can happen. I mean, this is something which is revolutionary. I think you should try it, Dr. British. So few brand names, if you could suggest. Yeah, I use Shining 3D on a daily basis. I've been using it for last 3 years. This is called as Aoral Scan 3. This is something which has worked like magic for me. I also have Itero as a scanner because if you want to do anything to do with Invisalign is calibrated to Itero. So we have to use Itero in that. Medit is another good scanner which is there in the market. And of course, Prime Scan, everybody raves about Prime Scan. That's supposed to be one of the best scanners in the world. Of course, you have a lot of scanners. Helios 500, yes, I have seen the scanner. Um, I have tried it out once, but I'm not an expert to comment on the different scanners, because I think you have to use it for more than just one case before you actually pass a judgment on. So, any other questions that we have here? Is that it? So, if there are no other questions, should we just wind up? Anything else is there? How much cost to invest? So, today the scanner cost is anything between 5 lakhs to 10 lakhs is a good amount to invest for a digital setup. So the beginning into digital dentistry is getting an intraoral scan. After you get an intraoral scanner, if it is a clinic, the second thing that you should be getting is a resin printer. With these two things, majority of in-clinic things can be done very easily. What would you do in a clinic when it comes to manufacturing? You want to give immediate provisionals. You don't want to wait for days to print a provisional. Today, you want to say you're doing a smile makeover. You've done the scan, you brought in the scan, you put in some teeth, you've designed it. If you're not able to do it, you send it to a lab, you get the design done, you bring it back within 1 hour, and then you print it. Okay, so when you print it in your own clinic, the provisionals are ready, you put it into the patient and send the patient. Patient is, wow, this is super. So in clinic provisionals can be printed. That's the first thing that you would print. The second thing that you would print is liners, where, as I showed you in the app, you just uh, get the sequence of the models, and the models are pressed, and you get the sheets, aligner sheets. You press it, and then you get the aligner. These are the first two things that you would do in the clinic. The next step would be to get a milling unit, and that is only zirconia and lithium disilicate milling. So when you can manufacture your own crowns. The third thing would be to get a metal printer, but that would make it a commercial app. So I think the resin printer and a tabletop milling unit are the two things that you would invest on. The printer today costs just about 2 lakh rupees. You get a very high quality, high definition printer. For a milling unit, it's a little more expensive. It would cost about 30 lakhs, but I think a milling unit is a third step that you would be taking. The first step would be to get a intraoral scan. Okay, so I think it's time. Thank you so much for sparing your valuable Sunday with us, and hope you have a very good day ahead, and hoping to see you more in Global Dental Academy programs. As I told you in the middle of the program, that we have a digital dentistry day sometime in June, which will be announced. It's a 2-day program which will be taken up, and we will show you implant planning, we'll show you smile designing, we will show you some crown designing, which can be the aligners. These are 4 different aspects that we will show you, and we will kind of try to make it very interesting with a lot of hands-on. That's something that we do. We want you to get your hands into the whole technology and experience it. So that's what we're going to do in June. Please tune into GDA on your social media pages and keep update to all our programs. Thank you so much. Namaste.